So let me start with this case. Okay, this is a 21-year-old gentleman who presented with melena, and his medical history is pertinent for significant cardiac issues, including a tetralogy of Fallot, status post-surgery. He has severe pulmonary regurgitation and a cardiac cirrhosis from right-sided heart failure. He also has portal vein thrombosis, and he had esophageal varices that were eradicated by band ligation, and he's known to have large gastric varices. Here is his upper endoscopy. Can you play it, please? So in the stomach, there's some altered blood, as you can see, and then there's this large cluster of grapes formation, fundal varices. And there were actually stigmata of recent bleeding, which is, let me see. Is that the pointer there? Which one is the pointer? This one? Okay, so the pointer is not working here, but anyhow, there was stigmata of recent bleeding on these large varices, and there were no other lesions to account for the bleeding. So, based on the clinical history and what you have available at your institution, not what you think is the best answer, but what you think you have available at your institution, what would you do in this setting? So, who would do sclerotherapy, alcohol-based sclerotherapy? Raise of hand. Nobody. What about band ligation? Raise of hand. Nobody. Glue injection? Quite a few. What about EUS guided coil and or glue injection? A couple of you. Tips. Okay. And BRTO? No. All right. So I think in this setting, for fundal varices, sclerotherapy and band ligation are potentially temporizing measures, but they are not definitive therapies because there's a high rebleeding rate with these therapies for gastric varices. And moreover, especially with band ligation, you can end up with a large ulcer with post-banding ulcer bleeding that can be torrential and life-threatening. Tips in this setting is not appropriate because of his right-sided heart failure. So we're really left with glue injection, EUS-guided angiotherapy if available, or BRTO if a patient has a gastrosplenorenal shunt. So here in this setting, we proceeded with standard glue injection, okay? At our institution, we use an 8-carbon cyanoacrylate, which is dermabond. And this has to be injected undiluted because of its delayed polymerization compared to histoacryl, which is more commonly used. So in this patient, the injection went essentially without difficulty. A total of 5 ml of the dermabond was injected at 2 separate sites in this cluster of large fundal varices. As you can see, it's still soft there, so there was a second injection site that was performed. And again, in this setting, everything went fine during the procedure. Okay. Soon after the procedure, so the patient was on 100% 2 liters nasal cannula. At about 8 minutes, his oxygen requirement went up to 5 liters nasal cannula with a saturation of 79%. 15 minutes, he's only 10 liters closed face mask, and he's saturating at 92%. And about 5 minutes later, he's on a ambu-bag with a saturation of 72%. He becomes unresponsive. 25 minutes later, we have to call a code because in his respiratory arrest. He goes in pulseless electrical activity, he becomes asystolic, and he dies on the table. At autopsy, as one would expect, he had massive bilateral glue-related pulmonary emboli, and that was exactly the case that Dr. Wong presented in his talk. So, pulmonary glue embolization is quite common after glue injection. This is a study that actually compared EUS-guided coil versus EUS-guided glue injection, but as a side aim, they obtained a chest CT in all patients who underwent glue injection to assess for embolization. And 47%, so 1 in 2 patients will have evidence of pulmonary glue embolization, albeit in this study they were all asymptomatic, so it's subclinical. You will also notice that the mean injection was only 1.5 ml. So that's a relatively small amount of glue for a 50% occurrence of glue embolization to the lungs. Dr. Wong alluded to this retrospective study from China, which is the largest retrospective study to date, with a in an incidence of 0.7% of symptomatic embolization following glue injection. In that study, the glue that was used was hysteracryl. But beware that the range, it goes anywhere from 0 to 4% depending on which study you read. So when I quote patients, the risk of embolization, I actually use a higher end, which is a 4% risk of symptomatic glue embolization. We are challenged in the US with regard to the use of glue for gastric varices. As Dr. Wong mentioned, number one, it's off-label. Number two, we're dealing with a relatively uncommon condition. And then that begs the question whether should all gastric variceal hemorrhaging be referred to a specialized center. And there may be some arguments for that. The procedure is indeed not standardized. As previously mentioned, different glues are available, and the volumes that are injected are also variable, as well as the dilution ratios between glue and lipiodol. And more importantly, in our setting in the US, there's a perceived risk of serious adverse events and lawsuits. And the glue-related injuries and deaths are underreported. How do I know that? It's because I do intermittently receive legal cases for review to assess the appropriateness of glue injection therapy for gastric varices in patients who have had severe complications or deaths related to glue injection. And evidently, these adverse events are not publicly advertised, and they are certainly not reported in medical journals. And as I mentioned, we do live in a litigious society, at least with regards to the US of A. So with regards to the glues, those are the two types of glues. You got butyl cyanoacrylate, which is more commonly used, but octyl cyanoacrylate is used in many institutions, including ours in the United States. As I mentioned, it has a longer polymerization time, and thus it is important as a means to minimize the risk of embolization with octyl cyanoacrylate, not to mix it with lipiodol because it will excessively delay polymerization and increase the risk of embolization. And I will also point you out, if you were to use octyl cyanoacrylate or Dermabond, it takes twice the volume of a glue as opposed to hysteracryl to achieve the same effect. So when you're using 2 ml for hysteracryl, expect to use 4 ml when you're using Dermabond, and that is an expected ratio of 1 to 2 with regards to these two glues. So based on that data that we have thought about alternative modalities to minimize the risk of glue embolization. And those are the two techniques that I want to review for you. One is EUS guided angiotherapy, which consists of fine needle injection of gauze followed by glue. And then the technique that we use, which is a combined interventional radiologic and endoscopic technique. So more on that later. With regard to EUS guided angiotherapy, namely fine needle injection of gauze, by the way, work in certain situations. It is effective at achieving hemostasis, but it is probably not as effective as glue for complete obliteration of varices. I do not do EUS, so this was provided by my colleague, Dr. Levy, and you'll notice that on picture E, he has a coil injected from a transesophageal approach, and he also has a coil extending outside of the esophageal wall to minimize migration of the coil, because yes, the coil itself can migrate and embolize. Now, as I mentioned, coil can be effective, but probably not as effective as EUS-guided fine needle injection of coil followed by glue. And this technique is promoted by Dr. Binmoller and colleagues and has been shown to be quite successful. Essentially, what is being done is an EUS-guided injection of coils in the varices, and that is immediately followed by glue injection through the same needle. Now, what is the rationale for doing this? Well, it is thought that the coils can be used as a scaffold to entrap the glue and minimize the risk of embolization. That's number one. And number two, that less glue is required to achieve variceal obliteration with this technique. The limitations, as Dr. Wong mentioned, are that, number one, EUS availability, that's an issue, but also the technical expertise. There's just a few endosonographers that are able to do this technique, particularly the injection of the coils. In their study from Bad and Binmoller's group, so this EUS-guided angiotherapy was quite effective at achieving obliteration of varices in over 93% of cases. But you will notice that they did use octylcyanoacrylate, which is dermaBond, but the volume injected was a mean of 2 as opposed to a mean of 4 to 6 in our study. But you still can get embolization despite this technique. So it's not a foolproof procedure technique to completely eradicate, to completely eliminate the risk of embolization. So in their study, they still had embolization issues despite the use of coal to minimize the risk of glue embolization. So let me switch gears now to balloon retrograde transvenous occlusion as opposed to obliteration, the BRTO technique, assisted endoscopic glue injection. This is what we think is an alternative approach for managing fundal variceal hemorrhage in patients with gastro or splenorenal shunts. Now, the gastro or splenorenal shunt is the major route for systemic glue embolization, okay? So on the picture, you can see the GR shunt, which connects essentially that cluster of grapes, gastric varices, right to the left renal vein, okay? So this is the mother of all veins that's gonna cause clinically relevant embolization of a glue. That shunt is present in over 85% of patients with fundal varices. And it can be detected by simply performing a contrast CT, abdominal CT with contrast, intravenous contrast. Now, Dr. Wong mentioned BRTO. So the BRTO technique essentially uses that gastrorenal shunt to occlude the shunt and then inject an alcohol-based sclerosant or foam into the gastric variceal complex. The problem with the alcohol is that it diffuses systemically, and that's why patients end up with a host of adverse events with injury to the lungs, to the kidneys, to the systemic circulation, to the heart, and whatnot. In addition to that, the catheter has to be left in situ for many hours to allow for the sclerosant to sclerose into the gastric varices and for thrombus formation. So the patient has to remain still up to 24 hours in some cases. So what we propose instead is to use both techniques. If you can play the video, please. Take what BRTO has to offer and what endoscopic glue injection has to offer. Okay, so in this technique, we would place a balloon occlusion right into that shunt, either via a transfemoral or a transjugular approach. Okay, and then this is followed immediately by endoscopic glue injection mixed with lipiodol. And this is done obviously in combination with the interventional radiologist. Okay, so from the IR standpoint, it facilitates tremendously the amount of work and skills that they need to perform this procedure. What are the advantages of this procedure? Well, number one, it provides you with real-time fluoroscopic monitoring, so you can actually see what the glue is doing in the varices. It eliminates glue embolization through the gastrorenal shunt. By occluding the gastrorenal shunt, it reduces variceal blood flow and causes relative stagnation of blood in the gastric varices, facilitating glue polymerization. And the glue promotes effective obturation of the gastric varices in one session only, without the adverse effects of large volume sclerosant installation as in BRTO. And also importantly, that catheter can be removed 10 minutes after you're done with the variceal injection, as opposed to several hours with conventional BRTO. So can you start the video, please? So this is a patient who had large fundal varices with stigmata of recent bleeding, as you can appreciate. You got an erosion right in the center of his pharynx, okay? This is pretty large, okay? It's larger than my scope. And this type of varices are the ones that really concern us with standard glue injection in terms of embolization. We did proceed with a contrast CT and indeed demonstrated that he has a gastrorenal shunt as pointed on the right. And if we do a CT in 3D rendition, you can really appreciate the proximity of the gastric varices to the left renal vein, how easy it is for the glue to embolize through that shunt, okay? So this is a BRTO assisted endoscopic glue injection. So first, in this case, the balloon occlusion of a shunt was performed through a transjugular approach, and this is followed by endoscopic glue injection. The mixture we use is 2.5 of dermaBond with 0.5 of lipiodol. and we inject the varices until we have complete obliteration of the whole variceal complex. And this happens usually with just one injection. As you can tell, immediately after injection, just on one side, the whole thing is obturated, okay? This catheter is then removed after 10 minutes or so, and what you're left with is obliteration of this large complex of varices. And evidently, you're not going to get rid of this variceal complex with just standard glue injection of 1 to 2 ml at a time. Okay, can you please play the video? So there was complete variceal obliteration at 6 weeks follow-up. This is what it looks like. It's all gone, and what you might see is just a residual retained glucose at the injection site. This is a case of recurrent gastric variceal bleeding. You can see on the top picture there are large fundal varices with a couple of stigmata of recent bleeding, and this is despite having a TIPS put in. So there's a subset of patients with gastric varices who are not going to respond to TIPS, even if a TIPS is totally patent, as was in this case, okay? So here we were concerned that not only he had a gastrorenal shunt, so that the glue could embolize through that shunt, but that the glue could also embolize through the TIPS itself. So here, to minimize that risk, we placed both 2 balloon occlusions, one through the tips and one through the gastrospinal shunt, followed by successful injection of the gastric varices with the glue-lipiodol mixture. All right. Can you pause this, please? Just hold it. Okay. Okay, that's fine. Just let it play. Can you guys see this? Okay. You can see what's floating there. Okay. This is actually glue, but in the inferior vena cava. So this case actually, during the procedure, a large chunk of the glue broke off and started floating towards the balloon, the balloon catheter. So the question is, what do we do now? If we have to deflate that balloon at some point. So in this setting, what we did is to place an IVC filter from a transjugular approach, and then by deflating the balloon, allow the glue to escape with a shunt, but it is being prevented from going to the lungs with this IVC filter. So that's why we do this technique, to minimize this kind of complication from happening and killing the patient. So we are going to publish our clinical experience very shortly. We are over 30 patients with this technique. This was presented about 2 years ago at DDW. With this technique, we are able to achieve gastric variceal obliteration over 95% of cases, and with a reasonable rebleed rate of only 4.5%. However, the procedure-related mortality was 0%, but we do have adverse events, and we do have embolization that can still occur despite this technique, okay? So it, again, just like EUS-guided angiotherapy, it's not 100% foolproof, but what I would submit to you, that it will prevent the embolization that truly matters, the one that's going to go through the GRS and that has the potential of killing the patient. So in this case, this patient actually was the one that we had to put the IVC filter in, and we were concerned that perhaps some of the glue broke off, a little amount of glue broke off during the balloon deflation, and we did get a CT scan showing that he indeed had some pulmonary emboli, but he was asymptomatic from that standpoint. Now you're going to ask me a question, well, doctor, I can't do this in the middle of the night in somebody who's actively bleeding, so how am I going to do this? Well, it boils down to essentially temporizing the bleeding, okay? So you can do this in 2 ways, well, 3 ways, including balloon tamponade. But the way we do this, if somebody is in the middle of the night who's actively having bleeding from the fundal varices, we're going to try and clip the bleeding site first, okay? If we can clip it, we proceed with clipping. That will buy us enough time to make arrangements to proceed with the combined IR endo procedure, and then proceed as appropriate. So clipping of the bleeding site is appropriate to again, as a temporizing measure, not as a definitive measure. Can you play the video on the right, please? Now, if clipping is not your method of choice and you're concerned about clipping the bleeding site, you certainly can bend the bleeding site, okay? So this is another technique that we use in the setting of active bleeding. We will put a rubber band right onto the bleeding site, and then we'll stop. Then we do the workup that is needed, and then proceed with the combined IR endo technique for definitive therapy of the gastric varices, okay? So again, in the acute setting with active bleeding, if you're thinking about something to temporize the bleeding, those are the two potential techniques that can be used. Okay, so in the picture on the right, after temporizing the bleeding, we proceeded with the combined IR endo procedure the following day, and then proceeded with definitive therapy with glue injection of the gastric varices under balloon occlusion of the gastrorenal shunt. Okay, and here it is post-injection. So this is my last slide. I won't talk about the left hand of the slide. This is for tomorrow. But again, if you're dealing with actively bleeding frontal varices and you need to control the bleeding temporarily, think of band or clip placement. And then you assess for definitive therapy. It could be TIPS or it could be BRTO. But in most cases, we do assess for suitability for glue injection. If a patient has no contraindication and they don't have a gastro-splenorenal shunt, we proceed with standard glue injection. In institutions where EUS-guided angiotherapy is available, that's another option. But in our institution, BRTO occlusion and glue injection is our preferred method of therapy. If a patient is not suitable for glue because of allergic reactions to the pyridol and whatnot, then we think about IR type of therapies. So take-home messages: subclinical pulmonary embolism is common during endoscopic glue injection of gastric varices. The gastrorenal shunt is the major route for systemic and potentially lethal pulmonary glue embolization. EUS-guided FNA of coil and glue may minimize the risk of glue embolization related to standard glue injection alone. And the BRTO occlusion assisted endoscopic glue injection effectively obliterates gastric varices while eliminating the risk of glue embolization through the GRS. Thank you very much for your attention.